So today we have one of our second year fellows giving a presentation. Usually we don't have them present until the second half of the year, but Elliot is just that good that we could have him present a little bit earlier. And he had a very cool case that he was going to be able to share with us. And just for the rest of the high rounds group who have not met Elliot yet, I just wanted to give a little background on Elliot. And Elliot will tell us a little bit about himself as well. Oh, and I just lost my bio, which I had right in front of me. There we go. Okay, sorry. So Elliot went to medical school at University of Mississippi, and then he did his internal medicine residency internal medicine residency at University of Cincinnati, finished in 2018, and then he did a chief residency year there before coming out to do his infectious diseases fellowship with us. And he did a stellar job with us. I am going to ask him two things to share with the group. One, Elliot, can you tell us what you're doing now for your research here, or at least a little snippet of what you're going to be doing and who you're working with? And then one fun fact about yourself that you'd like to share.
Yeah. So hi, everyone. I'm Elliot. Like Jill was saying. So right now in my second year, we've transitioned over to the research. So I'm working with Dr. Susan Little at the AVRC. Currently, I'm working on our HIV and STD testing co-testing program with one of our NIH-funded Good to Go clinics. And so right now I'm doing kind of a descriptive analysis of what benefits come about when you co-test both HIV along with STDs, looking at time to treat, and ideally looking at how that impacts the spread of not only STDs, bacterial STIs, but HIV. The overarching goal here is to transition over into molecular epidemiology of HIV, which I'm really interested in. So I'm just kind of getting started now. So it's all very new to me. I did not have a strong research background before coming here, but that's kind of the beauty of this program, is that we have lots of time dedicated to research. So I'm looking forward to learn. And Dr. Little is incredible.
Selling the program, Elliot. I love it.
Yeah, you see what I did there, huh?
I did.
Yeah. And so, I mean, so again, I'm from a very small town on the coast of Mississippi. I went to Cincinnati after that. And so I was tired of being landlocked. I'm really used to living close to the water. So now I'm here. I did do a degree in microbiology as well as a minor in Spanish. I lived in Spain for a year. And so Spanish, the ocean, San Diego was really the kind of perfect match for me. It fits a lot of my interests, not only in medicine, but outside of medicine as well. So, all right. So okay. I guess we get started, huh, Jill?
You can go ahead.
Yeah. So I could not remember if I had dreamed this title or somebody else stole it, but I checked around. It seems like maybe this is somewhat of a unique title anyway. So I wanted to talk about a case presentation of somebody I had on service when I was on our ON service, or HIV inpatient service. This was a Burmese refugee who came in with headache and was found to have a brain mass. So here we go. Oh, of course, no, I'm not. There we go. Disclosures. Obviously, I don't have any disclosures. I've got some objectives here for us. By the end of it, hopefully we'll be able to describe some MRI brain findings, not only with the diagnosis that we have, but other diagnoses as well. So what are the brain findings that we see classically in TOXO encephalitis, TB, and cryptomeningitis? We're going to touch on just a refresher of the definitions of TB based on their drug resistance patterns. And then I want to be able to list the differences between the WHO and IDSA and the American Thoracic Society treatment guidelines for MDR-TB. And then finally, describing the IDSA and ATS guidelines approach for selecting a treatment regimen for drug-resistant tuberculosis. So we'll start off. We have a gentleman that came to us at the end of May. He's 29 years old. He had a history of untreated hepatitis C, HIV, who was off of treatment since 2015. Previously, there were reports, this was reports only, of MDR-TB. I didn't have anything to really verify that initially. His TB and his HIV were diagnosed in 2008 in Burma, where he's from. And again, he came to us on the 27th of May. And he had 5 months of kind of this intermittent hemoptysis and headache. So, we say this all the time, and I don't like to fall into this caveat, but it was really difficult to get information from. And I think it was hard to tease out, whether this was because of just really, really low or poor health literacy, or whatever pathology was going on in his brain. But he was difficult to get a story from. He says he felt weak, generalized, really vague pain all over, and some malaise. But if you really press the gentleman, headache is the overarching, the worst symptom that he had. He did say, we're diving into this report of hemoptysis when we got consulted. And he said about 5 months ago, he started having a cough again, several weeks of frank hemoptysis with blood, really, kind of bright red blood. He couldn't tell us how much it was, but it seems like, starting 5 months ago, started to have some blood that he was coughing up. And that may have kind of been worse on some days and better on others. When you asked him, hey, in the last week, how was this hemoptysis? And he said, well, maybe I had a little bit, yesterday before coming in, but the day that he presented, and then when I eventually saw him, he wasn't really having hemoptysis. He was treated for TB in 2008 in Burma for at least 12 months, is what he said. Currently, when we saw him in May, he wasn't having any fevers, no weight loss, sore throat, shortness of breath, night sweats, nausea, vomiting, things like that. His medical history, again, HIV, untreated hepatitis C, and this history of TB. No drug allergies, no surgeries that we were aware of. And his mom and his dad were in good health in their 70s, and they didn't have any history of TB, malignancy, or any kind of underlying immune deficiencies. So socially, doesn't smoke cigarettes. He stopped drinking several years ago, but previously only drank socially. He did use IV drugs while he was in Burma, but he said he hadn't been using IV drugs since he left in 2013. He has sex with women only, but not in the past 2 years. He hasn't been sexually active. He lives currently in San Diego with his sister, his brother-in-law, and their small children. Their youngest is 4 years old, and they all live together in an apartment in San Diego. He works here as a sushi chef. His physical exam, we're going to move kind of quickly through this, but his physical exam, his vital signs were pretty unremarkable. He was afebrile, was sitting well on room air. He was, comfortable sitting up, alert and oriented ×4. The things that I will bring your attention to, and this didn't get updated, but his abdomen, he was soft and non-tender. He did have a little bit of distension in his abdomen. There was no fluid wave, and it was not tender. He didn't have any stigmata of chronic liver disease or cirrhosis. Otherwise, his exam was really unremarkable. The neuro exam was unremarkable when I took a look at him. Just some basic labs when we first came in. Of note here, obviously he's pancytopenic. His hemoglobin's not really super low, but he is a bit anemic. Platelets of 44. His renal panel is unremarkable, and then his LFTs over here were abnormal. Some elevation there. Nothing horribly abnormal, but you can see that. Here's a chest X-ray that he got on the day of admission, and it showed, based on my read, it doesn't look normal, but it's not grossly. There's no focal consolidation or anything. Their read said right upper lobe atelectasis, maybe. So we got a CT of his chest with contrast to kind of better visualize what was going on with these reports of hemoptysis and his history of tuberculosis. And the read really was right greater than left scarring that we see in the apices of his lungs. There's some lymphadenopathy, and all of this is really consistent with the reports of his previous TB infection. There was no obvious ongoing evidence of infection. They did note these prominent bronchial arteries that can be seen with hemoptysis, and then he had some varices there. Here's, the bang for your buck, right? It's really impressive. You don't have to do a radiology residency to note this. So just real, and this is just one slice, right? This was, those of us that were on the case, I mean, he had lesions throughout his brain, supratentorial, infratentorial, there was lesions in the cerebellum, but this one in the right frontal lobe was the most impressive. You can see here, it's extensive. There's lots of surrounding edema with significant mass effect here. It's mostly peripherally enhancing. And they say their read, and they kind of were very helpful, the radiologist here. They said this could definitely be, tuberculosis with maybe perhaps the early formations of a tuberculous abscess. And then these other scattered smaller lesions could be consistent with tuberculomas that we see throughout. They did, interestingly enough, talk about the location of one of the lesions in the left thalamus that, based on that location, could be consistent with toxoplasmosis as well. This is the picture I just showed you over here on the right, and then this is another kind of coronal view of this. Really significant, impressive intracranial lesions. So this is what we had when we walked into this case. And so the first thing, again, just to kind of be deliberate, what is the approach to somebody with a CNS lesion with HIV AIDS? You have to think of HIV encephalitis to begin with. And then obviously things that are non-infectious, neoplasm, progressive multifocal leukoencephalopathy, or a primary CNS lymphoma. And then the parts that we really enjoy, looking at opportunistic infections or other infectious causes of pathology. The top three here for AIDS patients, toxoplasmosis being the most common infection involving AIDS patients. A lot of retrospective studies and prospective studies reporting 15 to 50% of patients coming in with CNS complaints and evidence of brain lesions. Toxo is often the case. After that, you have tuberculosis and crypto high up on the list of potential, statistically, potential causes of this pathology. And then less likely things, Candida aspergillus and cocci. So I just wanted to put all of this out here early. These are the labs that we had. On the left are our, we were concerned about TB. The primary team was concerned about TB. So here you have it. We have a quant that was negative for whatever that's worth. We have lots of sputum. So it's multiple sputa negative for AFB on the smear, and the MTB PCR is negative. He had an AFB blood culture that did not grow anything initially, and a urine that didn't grow anything. And I did include here, this is, again, he came in on the 27th. This is, the bronch was done on the 3rd. And just to include this up front, the smear was negative and the MTB PCR was negative at that time too. Again, there wasn't really any, there was low concern of active infection based on imaging of TB, but we did get a bronch. Other basic things, COVID negative. He had a syphilis screen with an RPR that were negative. Blood cultures did not grow anything, and he had a cocci screen that was positive with a CF that was anti-complementary. Over here on the right, the Fungitel was, mildly, moderately positive, 85. Histo, urine antigen negative. CRAG from the serum was negative. The bronch, he did have H flu that was on there, otherwise unremarkable. His HIV viral load was 480,000, CD4 count of 45 and 7%. So significant, but not really surprising. His toxoserology, IgG was positive and his IgM was negative. So what do we do in this case, right? So at this point, we had this information, right? He has a very significant CNS lesion with mass effect, and really talking to radiology, he was very close to herniation. Any sort of definitive diagnosis, biopsy or whatever, was very risky in this patient, not only because of the risk of herniation based on this mass, but because his platelets were really, really low. So we didn't have a lot of places to go. He was sick when he was with us. Fortunately, his vitals were stable, but he was not doing well. And so we felt like we had to figure out somehow to empirically treat this gentleman. So the first thought I had is, this is a significant finding on imaging. Is there anything I can find in the literature to help me kind of tease out my differential diagnosis? And so what I wanted to do was go and see, kind of do a pictorial or radiology review of what classically you see in some of these in infections. So lots of these studies that I found were a bit older, but I still think valid in for our purposes. And again, starting with the most likely cause of infectious cause of CNS pathology in an AIDS patient is TOXO. And I think pathologically, the takeaway here is this is an abscess former, right? Abscess, abscess, abscess. You would see that, and that's why the classic ring enhancing lesion that we talk about with TOXO. But you can also get this, abscess, this solid nodular enhancement. And significantly, you're going to see a lot of edema and mass effect. You've got a pathogen that's necrotizing, right? And oftentimes necrotizing. The location, like the radiologist kind of extrapolated on, the basal ganglia, up to 75% of TOXO will be in the basal ganglia. So, the caudate, putamen, things like that. Otherwise, you can see it at this gray white junction and then in the posterior fossa. So just looking through some of these pictures and looking through, where and what TOXO can look like, I think our image, our patient this could fit, right? So that was high on our list. In the top here, you have the classic kind of ring enhancing lesions that are the buzzwords that we know for TOXO. And then here's a more significant down here. Lots of mass effect, lots of edema here. So TOXO was high on the list. Moving on to kind of what does tuberculosis look like? And this is from Madrid, and it's this is a prospective study, not a ton of patients, but they went and looked at their imaging finding that they had. And the majority of these people had 51% in this prospective study had hydrocephalus, followed by basal meningitis, right? And that's what we learned for our boards and everything, this basal enhancement that we'll see. It looks like a basilar meningitis. That's the majority of these patients. And that didn't fit, right? That necessarily, he didn't have this kind of classic findings for TB, but you can also get these tuberculomas. Oftentimes the tuberculomas, different from the tuberculous abscess, these can be solitary or multiple. They're ring enhancing lesions, but they tend to be small and they tend to have not a ton of edema associated with them, and often little mass effect. They are the result more often than not of hematogenous spread of TB when someone has active pulmonary tuberculosis. So, the radiology report did say, well, some of these could look like tuberculomas, but if it was hematogenous spread, I didn't have great evidence that this was likely in this patient. Now, tuberculous abscess, this is a rare form of the infection, but it could present and look like what we saw. They tend to be larger than the tuberculomas. So potentially TB abscess as the cause could fit with this patient. So I think TOXO, yeah, that probably fit. TB, tuberculous abscess, maybe some tuberculoma. It could have been the cause in this gentleman. So maybe those top two right now for our differential. And here's some picture of tuberculoma. I don't think this is small, but you can see some edema surrounding here, but there's no mass effect. And here's the same patient there with a tuberculoma. And then finally, crypto being the top kind of three. What does that look like on CT or MR finding? And it's meningitis usually. You can have some dilatation of the ventricular system, and then rarely these nodular enhancements of the meninges. That's the most common. Less common are these cyst-like filling of this perivascular space that you can see, this so-called Virchow-Robin spaces. And this is just the fungus gets into these perivascular space and they cause these cyst formations. Usually this is in the basal ganglia and usually it's symmetric. So I'm not sure that we had evidence of that in this gentleman. And then finally, cryptococoma, which is extremely rare, and it does prefer the choroid plexus. So we, knowing what the most likely presentation or imaging findings are for crypto, it seemed less likely in our mind initially. And I felt that TB versus TOXO was likely. And here's a picture of these bilateral kind of cystic dilatation here that you can see in the basal ganglia. And this is the Virchow Robbins spaces, these perivascular spaces. And this patient actually died. This was a prospective study, and he or she passed, and they did an autopsy, and these were actually filled with fungus, which is what you would expect to see in these cases. So, that was my initial approach to this patient. And so we have a long list of potential causes that that could be causing the pathology in this gentleman, but we needed some sort of empiric treatment and how to go about doing that. So after thinking about it, after discussing and looking at the radiology, we felt more likely TOXO, TB, or even primary CNS lymphoma, and less likely the other kind of infectious and non-infectious causes. So I do not think this is going to work. We tried it earlier and we were having some problems. So what I'll do for this is I just want to ask the question. You can unmute yourself and talk and tell me what you would do, or you can put your response in the chat, and then Jill and Marvin will help me kind of monitor that. So in this patient, what would you empirically cover for? I talked about my differential, and so I'm going to say, would you just cover for TB, just TOXO? Would you cover for both? Would you cover for both of those plus some more antimicrobial therapy, or would you just wait? And what I want to say about waiting is that you have to remember there's no definitive diagnosis or biopsy or anything like that in sight for this patient, right? His platelets are really low. He's on the verge of herniation. We're not going to get an answer anytime soon. So I just kind of wanted to see what people thought about this. Again, put it in the chat or unmute, and we can kind of talk about this.
We'll give everyone a couple of minutes. We're not even going to try it, right? There was no point in.
No, it's not doing anything. It looks
okay.
like.
Okay. So, and Dr. Matthews actually would also include acanthamoeba encephalitis and nocardia as part of the diagnosis, or the differential diagnosis.
Yeah.
Not including those, though, obviously, right? Which would people empirically cover for? No one seems brave right now. See if anyone. We'll give people a couple of minutes. And the interviewees, we're expecting you to. No, I'm just kidding. You can just listen. So it looks like we're getting some C's.
Okay.
Shannon wrote both, and I'm assuming that meant C, but I realize your D has a.
Well, Shannon was a part of this. So.
Yeah. And we have a Connie Benson, none, wait for diagnosis.
There we go. Yeah.
So a few different thoughts there, but it looks like the small majority, and that's quite small.
Yeah.
So I would like to interject.
Please, Dr. Benson.
Please.
Explain my E answer. So you've done a very nice presentation about all of the important things that are in the differential diagnosis. What I didn't get a very good feel from while you said he was sick.
Yeah.
The degree of severity of his illness in the context of how long you think it will take you to get tissue. And so this is a gentleman, I would not wait for serologic testing. I would not wait for cultures. I would not wait for some of the things, all of the diagnostic tests you ordered. This man needs a neurosurgery consult, and he needs a biopsy. And sometimes that gives us the answer. If it doesn't give us the answer immediately, then empiric therapy along the lines of what everybody else has chosen makes sense, obviously. But I really think this is somebody I would push for an immediate biopsy, and I would although certainly starting empiric therapy while you're waiting to get that done won't hurt, I do think he needs a diagnosis more than he needs immediate therapy. But that obviously depends on what your assessment is about how seriously ill he may be, and the trajectory of his illness. If you think he's crashing quickly, then obviously you're going to start therapy first. And then I think Chris is making a point about corticosteroids, but I can't quite tell from the response here, but.
Yeah, that was exactly right. You know, when we came on the case, you know, he was sick, but not, you know, there was not a huge rush initially. We felt along the same lines, is that we have to have a diagnosis, because, I mean, the treatment is just wildly different, filled with, especially if this guy truly had a history of multi-drug resistant TB, we're going to get into some horribly toxic medications for a very long period of time. So that was, you know, that was, I think, priority number one for us. And that took quite a while to, and, you know, daily approaching all of our consultants to help us get that. And so I think that once we realized, you know, he was still symptomatic, you know, day after day, and nobody, we're going to work towards a biopsy, but it wasn't going to happen anytime soon. We did pull the trigger to start kind of empiric therapy.
Yeah.
Yeah.
This is the most difficult part with these patients, because at the risk of saying something controversial, sometimes we refer to our neurosurgery services neurocontemplative surgery rather than neurosurgery, because they always want to sit back and wait for empiric therapy to work.
Yeah.
This is a situation where I think that's the wrong choice. If I had been able to say, I would have said D&E, you start your therapy and you get a diagnosis.
Yeah.
But we're often left in this position with these kinds of patients where we can't do the diagnostic procedure of choice ourselves. And so we're dependent on another service to get that done. And they prefer to sit around and wait for us to do something. So it's a very difficult situation. The hematologic complications obviously contributed to the decision not to go immediately with a surgical procedure. And a lot of people in the chat room are obviously commenting on the pancytopenia and the thrombocytopenia and the danger of doing a surgical procedure. But I think the danger also here is of him dying without having done a surgical procedure and with an inappropriate antimicrobial therapy, because you don't have a diagnosis. And I think this is particularly critical in the setting of someone who's previously been treated for multi-drug resistant tuberculosis. We know what kinds of bugs are coming out of Burma these days, and they are scary bugs. And I think it's very difficult to select an empiric therapy for multi-drug resistant TB at this point in time from people in that endemic area. Mm-hmm. You can't depend on almost any of the second line drugs to actually penetrate the CNS in realistic concentrations rapidly to achieve a rapid response in the central nervous system. And some of the new drugs, we're already starting to see emergence of resistance. Now you could say he was treated in 2008, so the likelihood of him having, if it's a relapse, of him having a bug that's resistant to bedaquiline and delaminid and some of our newer agents is low. However, you also don't know whether whether this is a relapse of a prior TB or whether he acquired another strain, which we're seeing more and more. About half of new cases of TB we see in sub-Saharan Africa are not relapses of prior TB. They are new organisms that they acquired from exposure in the background in which you have highly endemic tuberculosis. So it's just a complicated situation to even think about what drugs to use empirically in that. TOXO and other antimicrobial therapy, it may be a little bit easier decision.
Yeah. And that's exactly what I kind of wanted to touch on today, because that was, selecting an empiric therapy for potentially multi-drug resistant TB is extremely difficult, and not something I had a ton of exposure to prior. So that's exactly what I wanted to talk about. So we felt that at this time, again, we were going to approach neurosurgery, and we really thought that if this were TB, at the beginning, we didn't even have a bronch, and Holm was even hesitant to bronch this guy because of the risk of herniation. So we were really going to reach out to everybody that we could to try to get a diagnosis. Bronch, if there were TB in his bronchoscopy, that would be helpful. Neurosurgery, obviously, but that was something that was going to take a lot of convincing and a lot of work to get that to happen. And then we reached out to hematology oncology because he did have pancytopenia, and certainly it could have been because of his untreated HIV, because of whatever potential infection was going on, because of his untreated hepatitis C. He had lots of reasons to have that, but we also felt maybe he had bone marrow involvement from tuberculosis. And so we were asking them, can you do a bone marrow biopsy on this gentleman? And anything to get a diagnosis of if this is, to see whether this could be tuberculosis or not. And fortunately, because we involved hemonc, we were also, we had them weighing in about his platelets and how we can boost these platelets. Because again, we felt, highest yield, we need a brain biopsy. And so they were helping us out daily. We're infusing platelets, trying to get his counts up to a number where neurosurgery felt comfortable doing a biopsy. And they also used another drug, and I knew I'm not going to remember this drug, but it's it's a platelet stimulator, and it takes 5 to 7 days to kick in. But they were pulling out everything they had to help us get his platelets up in order to get him to biopsy. So that was helpful. But in the meantime, we felt we should cover for at least multi-drug resistant TB. So we wanted to take a dive and see what his TB history was. And this is when we involved our incredible colleagues at County TB, and they really worked wonders here. So his TB history, he was diagnosed September 4th in 2008 at a facility in Kuala Lumpur after he had classic kind of symptoms for TB. He was smear positive, and his culture was positive. At that time, his chest x-ray showed right upper lobe consolidation and cavitation. This is really, really busy, but this is everything. I mean, County TB, they called and were in contact with a physician in Kuala Lumpur that knew this guy. I mean, it was really incredible, the work that they were able to do, and really quickly. And so this is his diagnosis, right? So he was diagnosed in September 4th of 2008, started on RIPE therapy here. And then we have the lab results, and his TB was initially resistant to INH, streptomycin, ethambutol, and susceptible to rifampin, and kanamycin. And then, once they saw this resistance, he was switched around. Kanamycin and an injectable was added, and ofloxacin, a fluoroquinolone, was added. And then what I wanted to basically show is that he had a really resistant mycobacterium. Down here, this is kind of the final resistance. By 2010, he was growing tuberculosis that was resistant to INH, streptomycin, ethambutol, ciprofloxacin, and ofloxacin. And it is also resistant to rifampin here that I can show you. So he had a resistant tuberculosis in 2008, 2010. He was treated over here on the right. This was his final treatment with cycloserine, clofazimine, ethionamide, pyrazinamide, augmentin, kanamycin. And he was treated for 18 months. His cultures cleared. And then, so we have negative cultures here, May through June of 2012, as well as November 2012. And then before coming to the United States in February 6th of 2013, he had pre-departure smears in cultures that were negative. So the gentleman was treated for multi-drug resistant tuberculosis for 18 months and did have negative smears before coming to the US. So this was very thorough and very helpful history, especially since we were about to try to empirically start him on a regimen for concern for multi-drug resistant tuberculosis. This isn't going to work, I don't think either, but so just to refresh your minds, what is the definition of multi-drug resistant TB? I wanted to ask everybody that. Is it rifampin and INH resistance, rifampin and PZA, rifampin and thiamutol, rifampin and fluoroquinolone, or none of those? So just a few seconds just to see if, just to, ask a question that's pretty straightforward, I think.
We've got 5 A's.
All right.
But including me. But it looks like A is the
yeah. I not a tricky question here, but just wanted to ask. Rifampin and INH resistance is what you call multi-drug resistant TB. And so just to kind of go into the broader TB definitions based on their drug resistance, you have mono-resistant TB, self-explanatory. Polyresistant TB is resistant to more than one anti-TB drug, but not rifampin and INH. So it doesn't meet the definition of multi-drug resistant TB. And then you have the feared extensively drug-resistant TB that is resistant to, it's multi-drug resistant, so INH and rifampin, plus resistance to fluoroquinolone and one of these 3, amikacin, kanamycin, or capreomycin, resistant to one of those 3 second-line injectable medications. So he fits here for multi-drug resistant tuberculosis. And again, just to refresh everyone's memory, I think everybody here, the expert, this MTB rifampin assay that we have at Calm Lab, and it's a nucleic acid amplification test, and it obviously detects MTB complex, but it also tests for resistance to the RPO gene, which is responsible for greater than 95% of rifampin resistance. Something that so I think everybody kind of knows about that. This pyrosequencing, or PSQ, is perhaps something not everybody is familiar with. This is a nucleic acid amplification that the California Department of Public Health does. So if you have a concern for MDR or resistant tuberculosis, you can send the specimen to the Department of Public Health, and they do this PSQ, and that tests for more resistance. So not only rifampin resistance, but INH, quinolones, and injectable drugs. So that's what the PSQ is. And I think, this was probably my second or third potentially MDR case, and I wasn't initially aware of what this PSQ was, but there it is. So the next question is, we are concerned of MDR TB in this gentleman. He did have it in the past. What do we do empirically? First of all, how many drugs do you use, right? Do you just use 4 drugs like regular good old TB, or do we need to be more intense here? So I wanted to ask the question according to, I actually believe this is 2019, but according to the ATS, along with the IDSA guidelines for treatment management of resistant tuberculosis, multi-drug resistant tuberculosis, how many medications are recommended to treat during the intensive phase? I wanted to ask that. So specifically ATS and IDSA guidelines. At least 4 drugs, at least 5, 6, or 8 drugs.
Just 2 answers so far. We'll give people another.
Maybe it's because nobody's really aware, or less people are aware. So this is
it seems like it's we've got more answers now. We have 4 B's.
4 B's.
Including one of mine, which was a question mark B.
All right.
Francesca wrote, then it must be me.
Thank you, Francesca. Yeah, so we'll take that. So at least 5, and that is true. The exact, they say 4 to 6, optimally 5. And I did want to kind of, so different guidelines are out there. The World Health Organization, and I'm really glad Dr. Benson is on because she can keep me in line here. The World Health Organization, they say at least 4 drugs. 4 drugs is kind of their what they say, but they say 4 likely effective drugs, meaning you know the sensitivity or you're pretty darn sure that it's going to be sensitive. They do also go on to say many regimens, because of uncertainty, will include 5 to 7 drugs. But the ATS and IDSA guidelines say 4 to 6, optimally 5. And the difference there, so they're all kind of looking at these less than fantastic studies, right? But there are multiple, meta-analyses, observational studies across the world, and it looks like 4, 5, 6 drugs. They're the mortality and the chance of success are similar. The ATS and IDSA guidelines say optimally 5 because they anticipate that we're going to be using really toxic drugs and during the intensive phase. And so we may lose one of those based on side effects. And I think that that's really a big part of their justification of saying optimally 5, because they anticipate somebody not being able to complete the intensive phase of treatment for this. So that is what the ATS says, optimally 5 drugs.
So I think there's a couple of points that I think you started to allude to, but the issue isn't really the number of drugs, it's the activity of the drug. And that's where the ATS and the WHO kind of equivocate. Both of them sort of equivocate by saying you need 4 active drugs. So how do you define active drugs? Well, drugs that have not been associated with development of resistance or cross resistance with the other agents that you have to use. And so since you don't have, in many respects, at the time you initiate therapy, you don't have the drug susceptibility test results on all of them, then many of these guidelines do equivocate on the total number that you need to start during the intensive phase. So I guess the message to take away from here is that for an effective regimen, you need to have multiple active drugs in the regimen that target different mechanisms of action and can be tolerated sufficiently by the patient to complete an intensive and a maintenance phase of therapy. The whole idea of intensive and maintenance phase kind of goes away when you get to the point of treating MDR and XDR TB, because for most patients, you don't wind up stopping drugs during a 2-month intensive phase like you would with drug susceptible TB. And so many patients have to be on therapy with all of those agents for the full course of their therapy. A lot of the guidelines are changing actually by the TB world relatively rapidly, because a lot of data with new agents are emerging, and the newer drugs don't behave in clinical trials and in clinical practice the same way that most of the data for these ATS guidelines are based on. And these are often based on studies that were done. The earliest was 5 years ago, and the latest 30 years ago. So you're talking about relatively old data on which these guidelines are based. There's actually a new study and a new drug that was just approved by the FDA this last year that treated patients with extensively drug resistance with 3 drugs for 6 months. And with a 90% success rate, which is the success rate that you see with drug susceptible TB. So I think the whole paradigm for treatment of drug resistant TB is changing, and it depends on what drugs that one has access to and how active they are against the isolate that the patient is infected with. And so the whole concept is really moved away from this idea of just giving a standardized regimen to everybody to trying to tailor the treatment with an effective drug, a group of effective drugs that are active against that patient's isolate. We can do that better here in the US because we have access to all of the technology to tell us what to use. And we have access to most of the drugs, whereas other places don't have that luxury and wind up using standardized regimens that might contain 4 to 6 drugs or as many as 7 to 9 drugs, because they're giving whatever they have access to. And many of those are poorly tolerated, and they do expect to lose them before they can complete a course of therapy. So that's kind of the state of where things are right now.
Yeah, perfect. Thank you. Yeah, and so transitioning over to, how many drugs, from how many drugs to which ones to choose. And so there are several, again, resources out there. The WHO and the ATS, IDSA guidelines seem fairly similar. I did want to point out this Curry International TB Center, which is, they publish a kind of a clinician survival guide for treatment of resistant tuberculosis, including all of the different types of resistant TB. And these are their steps, which I appreciate a simple kind of stepwise how to do things. So this is the Curry TB Center. They say step 1, if possible, start with any of the first line drugs that are still available. If you know, so pyrazinamide and ethambutol. After that, then you would add on one of the later generation fluoroquinolones, either levofloxacin or moxifloxacin. And then this is different from the IDSA and ATS, but they say to then use in step 1 to use one of the injectable agents. The one thing you have to caveat this with is that I do not believe kanamycin is available here in the US. And then their stipulation for using streptomycin is you need to know if it's susceptible. And then a caution here, and I think one of the probably many reasons why this adding an injectable is lower down on the list when you look at the IDSA ATS guidelines is because cross resistance is not insignificant among these. And so if our patient, if you look back, his previously he was resistant to streptomycin, and so I think that this would this step here, adding any of these injectables, was difficult, even if we wanted to. So after step 1, then they say go on to your second line drugs, and here's a list of the second line drugs, and until you get to 4 to 6, and again they do say optimally 5. And then if you still haven't gotten to 4 to 6 or optimally 5, here's a list of other drugs that you can use. And to contrast that with, and in this case, in this patient, an empiric coverage, we tended to, I think our thought process, the public health department, TB folks were really helping us with this, but this was more along our approach to this. So this is the ATS and IDSA guidelines, and they say choose one of the later generation fluoroquinolones, like same as before. And then they prioritize these drugs here, bedaquiline and linezolid. And the fluoroquinolone and the bedaquiline and linezolid, they prioritize them. They give them a strong recommendation, even though the certainty of the evidence is not certain at all. They give them a strong recommendation, and they cite studies showing improved mortality, increased success of treatment using these drugs, and decreased side effects compared to a lot of these other drugs. They say that specifically for bedaquiline and the fluoroquinolone. They say linezolid has a similar mortality and increased success rate, but there's more side effects for that. So that's the reason why they focus on adding these prioritized drugs first. And then you move down here, you go on to the other steps until you get to these optimally, until you get to 4 to 6 drugs, optimally 5. So I'll show you what we did. So similar, this was our empiric treatment. And by the time we came up with our final empiric treatment, we had his previous sensitivities. So we had this gentleman on levofloxacin, linezolid, and bedaquiline. That fits with the ATS guidelines. And we also had him on cycloserine and meropenem. Meropenem is with clavulanic acid in the form of augmentin. That's lower down on the kind of preferred drugs. But a lot of this is we were struggling. He had a pretty resistant bacteria, but we, you not only, it's the availability of these drugs, right? So we did have in the process getting clofazimine, which if you look, it's higher on the list. It's up here with cycloserine, but that is not something that easily we can get our hands on. We did start that process, but it was going to take some time. Bedaquiline itself was also, I think cycloserine, linezolid, meropenem, levofloxacin, easy, right? We can get our hands on those pretty quickly. Bedaquiline did take a few days, and it took a lot of work from the public health folks. So like Dr. Benson was saying, it's toxicity, it's what the patient, what's likely effective in this patient, and it's what we can get our hands on. So that really makes it difficult. And this is where we landed.
Elliot?
Yes.
Connie actually asks, wasn't his previous isolate resistant to ofloxacin?
It was, yes. So yeah, it was. And I don't know, this exactly right. So we said 1, 2, 3, 4. So we felt that we had 4 potentially active drugs. We did know that it was resistant to ofloxacin, but we felt that with 4 likely effective drugs, and we do know that he did see cycloserine. He was on that before, so potentially this could be resistant to that. But we felt comfortable after long discussions saying these are likely 4 effective drugs. And we're still dealing with an empiric situation, and we weren't necessarily, it's a good point. We were unsure, but that was our kind of rationale behind it.
My next question to Connie was going to say what the cross resistance was, and she's answered that. There's 100% cross resistance among all of the quinolones, with the possible addition of high-dose moxifloxacin.
Yeah, there's a small body of literature that suggests with moxifloxacin at high doses, you can overcome low-level resistance, but the toxicity of much higher doses of moxifloxacin doesn't really warrant that. So, the fluoroquinolones are really, if this is a relapse of his previous isolate, the fluoroquinolones aren't doing you any good here.
And I guess, I guess that, so we what could we have done other than, I guess, amikacin in that case, but then cross resistance isn't it's not as high as 100%, I don't think, but, he did have a resistant streptomycin. I think we were kind of limited in what we could immediately give this gentleman. I don't know, Dr. Benson,
so obviously you're stuck with what you can immediately get your hands on, but I probably would have gone with delaminid here rather than an injectable.
Yeah, we did. Delaminid did come up, and it was a point of, we were having weekly meetings with the public health department, and it did come up. I think so. Fortunately, we figured out, we got a diagnosis on this gentleman before we got.
Yeah. So one point I will make here is that if he were being treated in South Africa, he would have had access to all of these drugs immediately. The fact that we're treating a patient with MDR or XDR TB here in the US, and we can't get access to what is considered the standard of care for these patients is astonishing to me, but.
Yeah. I think if we learned anything in the past pandemic is that our healthcare system is lacking in a lot of areas.
Elliot, just want you to note the time that it's 8:55. So.
Yes, and I'm almost done. Yeah. So we will. So this is what we were doing in this gentleman, as well as obviously high dose steroids, holding antiretrovirals, and then we gave him Bactrim to cover TOXO. We did this because it was an empiric instead of like sulfadiazine, pyrimethamine, because of there is a randomized controlled trial, although it's small, like 77 patients, that showed Bactrim is likely a good choice for this and has a better tolerability. And so because we didn't have a diagnosis, it was all empiric, we did empirically use Bactrim instead of other kind of first line, quote unquote, first line treatments for TOXO. So an empiric choice for MDR-TB, steroids, and empiric choice for TOXO in this gentleman. And then finally, on the 13th, we had a repeat MRI. Things were getting better as far as his platelet counts. He was responding to all of our infusions, and his empiric therapy. This is on the left, his repeat on the 13th. And things were looking drastically better, a lot better. Radiology did say, well, the response to therapy favors TOXO as opposed to TB, but we didn't really buy that because he was on high dose steroids, and I just felt like that completely muddled it, even though they did say this in their official report. So we weren't going to make any changes just based on this. But a couple of days after that, on the 15th, so I don't know, 3 weeks almost after he presented, we had a brain biopsy. This is all negative, and this is the part. So his MTB PCR was negative, his smears were negative ×2. All the cultures we had, including a modified AFB smear, those were negative. And this is where I pull the rug out from everyone, I guess. And here's his pathology, the stain for toxoplasma, and it was difficult. It wasn't a slam dunk case because there was a lot of background noise with the stain, but there were several convincing spots on pathology that looked like bradyzoites and a couple that looked like tachyzoites consistent with TOXO. And based on that alone, we stopped his MDR treatment and kept going with TOXO treatment. And then when I was reviewing the case again before presenting it initially to the county TB, I did look back because we did send obviously the University of Washington's universal PCR off, and it did come back positive for Toxoplasma gondii DNA. So that was our ultimate diagnosis. But again, I think the benefit here is the extremely difficult time we had getting a solid diagnosis. And again, his empiric treatment was very complex and required multiple people to come up with kind of best options for him. So I was wanting to share all of that with you. So if there are questions, I have probably 1 minute for questions. Thank you.
Shannon, do you want to unmute yourself?
Hey, yeah, can you hear me?
Yes.
Maybe mine's on. Okay. Yeah, Elliot, correct me if I'm wrong, but I think part of why we had the fluoroquinolones still on board was we didn't have that initial resistance testing back, because I know when we were picking the first regimen, we didn't even have his old regimens from way back. Yeah. So I think, yeah, part of it is we were kind of just, the county was trying to put together as many potentially new drugs and active drugs as possible. And then once we had that resistance history, that's when we did start talking about, I'm not sure, Connie, why they were more leaning towards pretominid versus delaminid. But that,
I was just going to say that I actually meant to say pretominid.
Oh, okay. And they were talking about, possibly following the NICS study regimen.
Right. That drug is approved for use and treatment of multi-drug and extensively drug-resistant TB, and delaminid is not. I meant to say pretominid when I was talking earlier, but pretominid and delaminid are the same class of drugs, and pretominid was the one that was in the NICS TB trial of 3 drugs for extensively drug-resistant TB. And it's thought to be more active than delaminid, although I'm not sure that's entirely true on the basis of one study with 90 patients. But there's a lot of work ongoing internationally with both drugs in combination therapy regimens. So with much less experience using pretominid, a lot more experience using delaminid, but all of that experience is outside of the United States. So
yeah. And unfortunately that conversation kind of died because it was right around the same time as his confirming his TOXO diagnosis. So we didn't hash that out completely in terms of whether or not it would be a good regimen for him. We tried to look into also CNS penetration of pretominid, which there's limited data obviously for a lot of the newer drugs. So
well, now you have the data for the next time it comes up. Well, just bearing in mind the time and people starting to trickle off, I really want to thank Elliot for a really fantastic presentation. I think we haven't heard about tuberculosis in a while, so it was nice to bring it back. But again, thanks, Elliot, and thanks for everyone for joining. Have a great weekend, and we'll see you next week.